Okay, guys. So another topic which I am covering today is about the radiographic anatomy of an intraoral periapical radiograph. First of all, if they ask you and they give you the film, because most of us are now accustomed to see the digital radiographs, and even if at times, like in our student life, we would have used this film radiograph, probably we would have forgotten that how to place the radiograph and how to orient it and how to analyze it. So first of all, remember that there is this embossed dot over here, or notch, or whatever you call it, the convex surface. It should be facing you. It should be facing the X-ray machine, and the deep portion would be towards the tongue of the patient. Remember this. And it should be on the occlusal surface. Like if you are using it on the lower side, so again, it will be on the occlusal surface. If you are using on the upper arch, then it will be on the towards the occlusal aspect. Remember these things. Easier way to orient and see, and to see the left and right, like just if you will be holding it, so the notch is towards you, you will be able to see whether it is left or it is right, or it is like my left is patient's right and my right is patient's left. Remember this. And this dot will be towards the occlusal surface, so we will be able to see whether it is upper or it is lower X-ray. Remember these things, these points, before we proceed further. Well, this is what we see on the radiograph when the radiograph comes in front of us. So we are able to see the dentin, we are able to see the enamel, and we are able to see the pulp chamber and the pulp canal. We are able to see the periodontal ligament space. Then we are also able to see the lamina dura, and we are able to see the what do you call it, nutrient canals as well. Well, remember that cementum is not visible on the normal radiograph. Cementum is only and only visible when there is hypercementosis. Why cementum is not visible? First of all, it is very, very thin. Secondly, its radio opacity is similar to the radio opacity of dentin. So it blends with it. Remember this point. Now let's proceed. Here we can see another case, and we can see that one tooth is still in the crypt. It is developing. It is just recently erupted, so the apices are not closed. And we can see the interdental area. Remember that if there is no any, what do you call it, periodontal problem, so the crestal lamina will be, this is the crestal lamina, it will be radio opaque. And there is no any radiolucency. The corners will be very sharp when it will be joining the lamina dura, and will be having the same radio opacity as of lamina dura. And if you just have one and the other cemento-enamel junction over here, and you join it, so it should be almost parallel to that imaginary line, which is joining the two adjacent cemento-enamel junctions. Remember these points. If there will be a periodontal problem, so what is going to happen? Either it will be an angular bone loss, or it will be a horizontal bone loss. Angular bone loss means that the bone loss, it is not going to be parallel. That bone, the residual bone, is not going to be parallel to that imaginary line between the two adjacent cemento-enamel junctions. But horizontal bone loss, the residual bone surface will be parallel to the imaginary line between the two adjacent cemento-enamel junctions. This is the point. Remember this. And of course, it will be at a lower level. If there is no any bone loss, as I told you, first of all, we check about the radio opacity, and there is no notching, there is no any like lost radio opaque area. Second thing is it will be just 2 to 3 millimeter apical to that imaginary line. Remember these 3 points. Okay. If there will be a periodontal problem, then remember that there will be thickness of the periodontal area in the coronal region. And if there will be a pulpal involvement due to trauma or due to caries or whatever, so remember that the thickening of the periodontal ligament will be in the apical area, apical half. These 2 points you should remember. So you will be able to see whether it is pulpal involvement causing this thickening of the periodontal ligament space, or it is the periodontal problem which is causing the thickening of the periodontal ligament space. Keep these 2 points in your mind. Is it clear to everyone?
Yes, boss.
Okay, great. Now, anatomical landmarks distinguishing maxillary radiographs from the mandibular radiographs. Area, incisors, canine, premolars, and molars. So in incisors, in maxillary radiographs, you will be able to see the incisive foramen, median palatine suture, nasal fossa, nasal septum, anterior nasal spine. And in the mandibular radiograph, in the incisor region, you would be able to see the lingual foramen, genial tubercles, nutrient canals, mental ridge, and mental fossa. Well, in the canine region on maxillary radiograph, you would be able to see that typical inverted Y, which I will show you in a couple of minutes, and the lateral fossa. But on the mandibular radiograph in the canine region, we do not have any distinct anatomical feature. On the premolars in maxillary radiograph, you would be able to see the maxillary sinus, whereas in mandibular radiograph, you would be able to see the mental foramen. On the molar region, in the maxillary radiograph, you would be able to see the maxillary sinus, zygomatic process of maxilla, zygoma, maxillary tuberosity, hamulus, as well as the coronoid process of mandible is visible on the maxillary radiograph. Remember that. I will show you. Mandibular radiograph, in the molar region, you would be able to see the mandibular canal, external oblique ridge, mylohyoid ridge, and the submandibular fossa. Well, radioopaque and radiolucent features. On an intraoral periapical radiograph, radioopaque will be bone, radioopaque will be border or wall, process, ridge, spine, tubercles, and tuberosity. Radiolucent will be a canal, foramen, periodontal ligament space, a fossa, a meatus, a sinus, a suture, etc., etc. Suture between the two bones. So how we are going to identify a radiograph if it is given to you, whether it is of maxilla or mandible, coming from the anterior region or from the posterior region of maxilla or mandible, looking at certain radioopaque and radiolucent features, we will be able to identify, like in the anterior region, the radioopaque features will be nasal septum, anterior nasal spine, the inverted Y, soft tissue of the nose, and radiolucent will be median palatine suture, the incisive foramen, nasal fossa, and lateral fossa. Whereas on the posterior region, the radioopaque will be floor of the sinus, septum, zygomatic process, zygoma, zygomatic arch, maxillary tuberosity, then pterygoid plates and hamulus, as well as the coronoid process of mandible will be visible. The radiolucent feature, it will be maxillary sinus. For mandible anterior region, the radioopaque will be genial tubercles and the mental ridge. And radiolucent features will be lingual foramen, which is between the 4 genial tubercles. I will show you the picture, and the mental fossa. Posterior region, radioopaque features will be external oblique ridge, which we also call only oblique ridge, and the internal oblique ridge, which is also called mylohyoid ridge. And the inferior border of the mandible and the If a torus is present, then torus would be visible. Radiolucent mental foramen, submandibular fossa, and mandibular canal or inferior alveolar canal. So over here we have a schematic diagram, and we can see drawing of the maxillary midline, outline of the nose. This is the outline of the nose. Then we have the incisive foramen. Keep in mind that incisive foramen, normally it is between the two central incisors and below the apices of the incisors. In case this radiolucency is enlarged and is going beyond the apices, then it will be a cyst. Then it will be a cyst. It could be heart-shaped or pear-shaped in form, or it could be just oblong type of, or football sort of thing. Any of these features. Then we have this lateral fossa over here. Lateral fossa will be between the central incisor and the lateral incisor. Then we will be having the nasal fossa. We will be having the nasal septum, then anterior nasal spine. Then we are having the border of the nasal fossa. Then we are also having the median palatine suture over here. At times, we all like this very, you can say, not very visible, but you can say that a little bit opaque line over here. You can see one opaque line in this region as well. And that is the shadow of the lip. Remember that. So if you will be seeing two opaque lines like this, so one will be lip and the other one will be the nose, shadow of the nose. This is what we get the picture when we take the intraoral periapical radiograph of the anterior region. And this is the actual radiograph. Now over here we can see all these things. The incisive foramen, we can see this is the incisive foramen. Then we can see outline of the nose. This is the outline of the nose over here. If the lip outline was present, it was present over here. Then we can see the lateral fossa. This is the lateral fossa, this whole area. Then we have number 4, nasal fossa. Then we have the nasal septum, this area. Then we have the border of the nasal fossa, this area. Then we have the anterior nasal spine and the median palatine suture. At times, question could be asked that, is it a fracture? No, it is not a fracture. It is the median palatine suture. You have to be confident. This is the canine region. And in canine region, as I told you, you will be able to see the lateral fossa and you will be able to see the inverted Y. This is the inverted Y. Inverted Y is due to the nasal fossa and the maxillary antrum. So let's see the X-ray. Actually, this is what we were mentioning, the inverted Y, like this. And this inverted Y is, as I mentioned already, it is due to the nasal fossa and the maxillary antrum. This is the lateral fossa over here. So far, so good. Everybody's okay? Yes, no, maybe. Yes, this is the overlapping due to the change in the angulation of the arch from the canine to the first premolar. And this overlap usually comes. These two radiolucent areas around this radioopaque area, we call those MAC bands. These are called MAC bands. Soft tissue image, I told you earlier that you can see the shadow of the nose and the shadow of the lip. So already we know about it. Now, maxillary premolar region. In maxillary premolar region, you would be able to see the maxillary sinus. You would be able to see the recesses of the maxillary sinus in this area, septum. Then you would be able to see the zygoma. as well. And if you are taking the X-ray not in the parallel technique, you are taking it in the bisecting technique. Usually this zygoma, it covers the apices of the, like this. It covers the apices of the molar, and that is not a very good thing in case of endodontics. It would be giving you trouble in finding out if your file has reached to the working length or not. Here we can see the X-ray. This is the sinus. Then this is the zygoma we are seeing. And this is the lower border of the zygoma, number 6, inferior border of the zygomatic arch. This is the sinus. So at times it covers the apices as well if you are taking the X-ray in bisecting angle technique. This is the molar region. And here, apart from seeing the sinus and the zygomatic arch and zygoma, we can see the hamulus. This is the hamulus. This is the tuberosity. And this shadow. At times they can ask you about this shadow. What is this? This is the coronoid process of mandible. Let's see on the actual radiograph. This is the coronoid process of the mandible. And this is the tuberosity. This is the zygoma. And here it is almost covering the apex. If the angulation was a little bit more, then it would have covered the apex of the, this is the tuberosity area. This is the lateral pterygoid plate over here. Another, here we can see the hamulus and tuberosity. We can see the coronoid process and sinuses. So far, so good. Everybody is okay? Yes, no, maybe.
Yes.
Okay, great. This is lower anterior region, incisor region. And here you can see the mental ridges and the 4 genial tubercles around the lingual foramen. If the angulation is more acute, then you would be even able to see the lower border of the mandible. Like this. This is the X-ray, actual X-ray. And here you can see the lingual foramen and the 4 genial tubercles around it, then the mental ridge. At times, a shadow of the, they can ask you what is it. If it will be quite diffused radio opacity in this area, unilateral or bilateral, then it will be torus. Remember that. This is how the torus would be most commonly visible. And as I told you that in the mandibular canine area, we do not have any specific landmark. At times, they can ask you about the nutrient canals. So these worms-like appearances, they are nothing but the nutrient canals. Here we can see on the radiograph, this is the shadow of the torus, and this is the nutrient canal over here. Usually, another question could be asked that in upper anterior or in lower anterior or in upper posterior or in lower posterior, in which radiograph we are able to see more commonly the nutrient canals, it is lower anterior region. This is a torus. This is the oblique ridge, mylohyoid ridge. Then we can see the inferior alveolar canal and the mental foramen. At times, what happens, the termination of the inferior alveolar canal is not very straightforward. It firstly goes anteriorly, then it comes back, and it terminates like this. This anterior loop is also formed. So in case if they will ask you about the designing or placement of the implant, then keep in mind that we will keep at least 5 millimeter, in case of this anterior loop, 5 millimeter anterior to this anterior loop. If it is straightforward, then 5 millimeter from the anterior border of this mental foramen. In case of, if you see the loop, This is the catch over here. So always check for the loop over here, anterior loop. This is how the mental foramen is. Yes, another very important thing is if you are seeing only one radiolucency and you don't see any pulpal involvement or any other reason that this radiolucency is present, then between the two premolars, it is the mental foramen. Mental foramen does not have very consistent place. At times, it would be appearing somewhere here. It would be appearing here. It would be even at times attached to one of the premolars as well. So it could be having various locations. Remember that. This is the mandibular molar region. We can see the external oblique ridge. Then we can see the internal oblique ridge, and we are able to see the inferior alveolar canal. We are able to see the submandibular fossa. Submandibular fossa is actually the diffused radiolucency because of the submandibular gland. At times, they can ask you about some radiolucency, which is at the angle and below the inferior alveolar canal, what it is. So those are the salivary gland inclusion areas or Staphny defects. Don't call those now Staphny cysts. We used to call those Staphny cysts, but they are actually now called the Staphny defects. Remember that. And that those are actually during the development, inclusion of the salivary gland, it leads to the formation of those. They are never above the submandibular, above the, what do you call it, inferior alveolar canal. And at times they can ask you about just accidental finding, very obvious radiolucencies over here. But the apices would be quite sharp. That would be the traumatic bone cyst. What radiolucency it is just traumatic bone cyst. So you have to be like, there is no fear in saying that what it is traumatic. If you see very like clear cut and the apices are sharp, they are not resorbed or they are not undermined due to the pressure of any cyst. So those are the traumatic bone cysts or simple bone cysts. Another mandibular region, you can see, as I told you about the crestal lamina in healthy, just 2 to 3 millimeter below the imaginary line. This is the submandibular fossa. This is the inferior alveolar canal. Another one. Here the inferior alveolar canal is in close vicinity of the molar. External oblique ridge, space loss due to extraction of the tooth some long ago. So over here, we are done with this lecture, and hopefully it's going to help you in your